Next up, we'll have Kate McCoy, who's the Youth Risk Behavior Survey Coordinator, and Gregg Curtis, who's the School Counseling and School-Based Suicide Prevention Consultant. They're both with the Wisconsin Department of Public Instruction. They'll be discussing data from Wisconsin collected through the Youth Risk Behavior Survey, as well as initiatives at DPI and its school districts to help prevent suicide among high school students and other youth. After their presentation, we'll have an opportunity for some audience questions. So we'll take a break after their talk for that. All right, thanks.
Thank you. Can you hear me? Okay, great. So as Sam said, my name is Kate McCoy. I have the pleasure of overseeing the Youth Risk Behavior Survey at the Department of Public Instruction.
And I'm Gregg Curtis. I'm the school counseling consultant and one of the leads on the school-based suicide prevention work we do.
So I will just kind of give you some of the highlights from the Youth Risk Behavior Survey data from Wisconsin that are relevant to this conversation. For those of you who are not familiar with it, the Youth Risk Behavior Survey is a survey of, in Wisconsin, we do high school students for our state level data. We use a representative sample of public high school students, and it is a survey that is sponsored by the CDC and administered in almost every state in the nation, or some variant of it is administered in every state in the nation. We also have some locally collected data across the state, but our official statistics are what I'm going to be presenting on today, and they're at the state level rather than county level. We don't have the sub-estimates at this point at the county levels. So we collect the data every 2 years. So I'm going to be presenting based on the 2017 information. We're back in the field in next month with schools starting in January for our 2019 data. So very quickly, Sarah said that what we can see in vital statistics is the tip of the iceberg. So with a survey, we have just a little bit more of what might be happening underneath the water for young people, because we're asking folks prior to or in the middle of any kind of mental health crisis what other things they may be experiencing, and we're able to kind of look across those responses. So in general, in 2017, we see in Wisconsin that there are very high mental health needs across the population for high school aged youth. We started asking anxiety in 2017. We hadn't included that question before because we heard from the field that it was a very large concern among K-12 educators. And so those are our statistics there. The gender breakdown is quite significant, not reported here, but that anxiety number splits roughly equally between males and females. So you have about 30% of males who say they've had a significant episode of anxiety in the past 12 months, and half of high school females. So these are definitely things that we want to be paying attention to. We also ask about suicidal ideation and behavior. So we have questions asking about, in the past 12 months, have you seriously considered attempting suicide? Have you made a plan about attempting suicide? Have you actually attempted suicide? And have you been treated for an injury as a result of a suicide attempt? And so here, you can see the question about considering suicide. We are generally seeing increases in the suicidal ideation, driven mostly by females. So as Sarah was saying, there is a gender difference in terms of the rates of change that we're seeing. And we're also seeing that reflected in vital statistics. So actual suicides, according to the CDC, are up across all age groups and genders. But one of the most remarkable upticks is in those young women. And we're seeing that reflected in ideation as well. So no one knows exactly why. I'm not going to pretend that we know exactly why. There are some interesting things, though, that are emerging from the data that we see in Wisconsin, that we see nationally, and that are beginning to be topics of discussion in schools and by scholars. So one of the things that we see is students are reporting less sleep. And we know that that's important. So here, just to remind us of how important it is, I've broken down the responses to self-reported depression and anxiety by the amount of sleep that students report getting in an average night. So it makes quite a big difference. And so we've seen a drop from more than a third of students saying that they get 8 or more hours of sleep to closer to a quarter, I believe. So that is, so we're noticing sleep is going down. At the same time, we're noticing that screens are going up. These might be related. They might not be. And we're going to ask some additional questions going into this cycle to try to figure out, is it that they're on their screens and therefore they're not getting sleep? Quite plausible, something that people report anecdotally, something we hear a lot about. So we see there's more screen use. We have seen an uptick in teen self-reported depression. Like I said, anxiety, we have one data point, it's very high. And we do see kind of this dose response in the data between screen use and these self-reported anxiety, depression, and suicidality issues, particularly at the upper end. So among girls who spend the most time on screens, 70% report that they're anxious. So those three top points there are what we can actually see in the YRBS data, the increased screen use, depression, anxiety. And those other points are kind of what we're hearing from the field, what we're wondering about, and what is being discussed in some of the research literature that's coming out right now that's making a splash. So, what might be a mechanism? We're hearing that kids can never get away from the social pressures and just the constancy of having to respond to their phones. And that this might be exacerbating some of the vulnerabilities that adolescents have always had. The need to compare, to measure up, to be included, those things are not new, but to what extent are those things being exacerbated through their connectivity? Another line of reasoning that people are looking into is we know impulsivity is important when we're looking at things like suicide prevention. This book that has just been coming out and making a splash about, that I reference at the bottom, is also asking, are we sort of seeing an anti-CBT in society? Are we, through as parents, educators, and through social media use, inadvertently providing messages that the world is dangerous, that you're vulnerable, that you need to be protected, that there's trolls all over the place who are going to exploit anything that you put out there. So, is there something that that we could be addressing? Again, those latter points are going beyond what we can see in the data, and it's putting it out there as a conversation for us to discuss. Again, we are seeing less sleep. We're also seeing students are saying that they're less healthy, which is really interesting because a lot of their health behaviors look better. So subjectively, they feel less healthy, which I think is interesting, is they're reporting less mental health, they're reporting reduced physical health as well. But we're seeing that they're drinking less, they're smoking less, they're eating healthier. So there's other things that would lead us to believe that they should be feeling healthier. So in other research, Jean Twenge wrote the book iGen, which many of you are probably familiar with, where she looked at national YRBS data, as well as the Monitoring the Future survey and some other surveys, and found some additional measures in terms of youth showing steep declines in overall life satisfaction, sense of meaning, the thought that they can overcome regular day-to-day challenges. There's a reduction that she's seeing and others are seeing in perhaps some of the real social contact as opposed to virtual social contact. So kids are not going out drinking as much on the weekends, and that's good, and we've been working in public health for a long time to make that happen. But now what if they're staying in their bedrooms on their phones all night? And is that perhaps having some unintended consequences? So what's maybe being displaced here when we're thinking, they're much safer, they're not driving, they're not drinking, and how can we engage some of those maybe more positive, active challenge behaviors that are not risk behaviors that adolescents might need for healthy development? So some folks are looking at, are we seeing a delay in a lot of the traditional adolescent behaviors that mentioned, that traditionally indicate greater responsibility? And I'm sure you can talk about that from the higher ed perspective as well. So kids are feeling perhaps more vulnerable as they're taking on less challenges and feeling more protected. So just briefly, I want to touch on what do we talk to schools about more particularly. Sarah talked about connectivity and being connected. Actual social connectedness and institutional connectedness as being important. We look at how connected students feel to schools in their sense of belonging at their school. And we see a distinct difference between those who are considering and not considering suicide. And that is something that we emphasize because it's malleable, and we hope that we know that when schools make a push to increase that sense of belonging for all students, then it can have an impact on that sense of suicidality. So there are differences between which groups both feel a sense of belonging and report being at higher risk of suicidality, which I have there. But an important reminder that even those folks who are in the higher belonging class, we are very much students who we need to pay attention to. So we have a lot of white straight males in Wisconsin who are at very high risk of suicide. We know that those attempts need to be taken extremely seriously. Okay, so I'm going to hand this over to Gregg to talk about what are we doing in schools right now to help youth.
Great, thanks, Kate. So I get to talk about practice, educational practice. And I'm going to do that through briefly talking about 3 different areas. What does the law say? What kind of programming is in place? And then what kind of professional development is there for educators around suicide prevention? So you can see on the screen here, we've got administrative rule and statute that really talk about 3 main areas. They talk about educating students. They talk about what needs to be in health curriculum, and we know that health is a graduation requirement in the state of Wisconsin for high schoolers. And then we talk about, or statute 115 talks about what are some of the requirements of DPI. So you can see that when it comes to educating students, we have to, as one of our educational goals, talk to students about suicide prevention. It doesn't say, I mean, as a local controlled state here in Wisconsin, this is the what, but we don't dictate the how. So we know that schools have to do this, but we don't necessarily tell them how they have to do this. So they can talk about it in literature, they can talk about it in health, they can talk about it in first aid, they can talk about it in multiple places if they want to, but they have to talk about it. And the health curriculum, again, health is a graduation requirement for high schoolers in Wisconsin. Health has to include something around suicide prevention. Therefore, every high schooler that graduates from high school gets some suicide prevention education. And when we think about education around suicide prevention, what we want to do is we want to help them acquire skills, help them acquire knowledge, help them acquire skills, and then practice those skills and apply those skills in multiple contexts. So the fact that we've got the opportunity to address suicide prevention in multiple places is a really big benefit. Around the requirements for DPI, there is a requirement that we have to provide assistance to schools, and we have to do that through training staff, and we have to do that through providing a clear practice and clear indication of how do we look for the warning signs, what do we do when we see the warning signs, and how do we refer students for help. And then the final piece is we have to provide our educators with resources. And DPI is mandated to provide a model notice that a large majority of our schools take our model notice every year and they post it for their staff to see. And they bring it up in services so that their staff is aware of, here are the warning signs, here are the things that we can do, here is the protocol in our school policy on what to do if you believe a student is suicidal. So that's the laws. Around programming, there are really 3 different areas, and there's adult-led programming, there's peer-led programming that's supported by adults, and then there's kind of an overall prevention. And Representative Ballweg mentioned one of those peer-led, adult-supported programs in Hope Squad. And it's certainly a program, but it's not the only program. And again, at DPI, we can't tell folks what to use. We can just give them suggestions. And both Sources of Strength and Hope Squad are evidence-based, peer-led, adult-supported programs. The adult-led programs where we impart knowledge and skills to the students, and it's adult-led, include the signs of suicide. And Representative Ballweg mentioned QPR. Signs of suicide is another version of gatekeeper training that uses a different acronym. It uses ACT, acknowledge, care, compassion, tell, and talk. So again, it's helping students acknowledge the fact that there's an issue, show care and compassion for the student, their friend, the person that's presenting in front of them, and then getting them to talk to somebody and refer the student for some help. We've got some links there embedded in this slide. One of them is to the DPI suicide prevention curriculum. Again, we don't tell folks what they have to use, but we provide a free curriculum that's based on, that can be implemented with grades 7 through 12, that talks about gatekeeper training. So it's warning signs, and then it's what to do. And it gives opportunities for students to practice the knowledge and the skills that they develop during the curriculum. There are some other programs that can complement suicide-specific programming, and those are broken down into those two main areas: promoting positive and safe school climates, and then supporting transitions or increasing belonging. Sarah mentioned mindfulness and stress reduction. Those would certainly fall under that group of promoting positive and safe school climates, because it's something that everybody does. And when we think about positive behaviors, interventions, and supports, the universal level of that is services that all students get. So PBIS is definitely a program that complements suicide-specific programming. Social emotional learning is huge right now, and there are lots of different programs out there that schools can utilize to help their students develop the social and emotional competence they need to face the barriers to their success every single day. Anti-bullying, absolutely. That's definitely a complementary program. A program that complements the anti-bullying then is restorative practice. If bullying does occur, how do we rebuild the community, and how do we repair the damage that has been done? And then we've got multiple suggestions there, or at least examples of programs that support transitions: link crew, tribes, and connections. If we think about professional development, here are some of the main areas that we provide professional development, or we partner with a premier partner in the Wisconsin Safe and Healthy Schools Center to provide, including a 24/7 accessible online gatekeeper training. Representative Baldwin mentioned QPR can be learned in an hour. Our gatekeeper training module is about 15 minutes, and it does give us a thumbnail version of, here are the warning signs, here's what to do. And it gives people that engage in that training an opportunity to practice what they learn. SBIRT, screening, brief intervention, and referral to treatment, is another mechanism to help educational professionals intervene, as well as trauma-sensitive schools, and then that social emotional learning component. So we've got laws in place, we've got programming that we utilize and that we point folks to, and then we've got professional development for educators as well.